Good evening. Welcome all to the sixth teaching program of the Master Series of Spine Society Delhi chapter, where we try to bring in a focused topic for discussion with our esteemed faculty from Delhi Spine Society and a national faculty on a very particular topic. Today's topic is a very interesting topic and a very hot topic. All the spine surgeons now all want to become endoscopic surgeons, and we have stalwarts from Delhi Spine Society having having to conduct this important meeting. So now I invite Dr. Arun Bonot, who is the convener for today, and I also welcome Dr. Karuna Karan, who is a national faculty for today's master series. Over to you, Arun.
Thank you, Rupinder. Thank you, Guru. And as Dr. Rupinder shared, that Spine Society Delhi chapter has taken this endeavor to conduct some masterclass series on select topics. And as Rupinder correctly said, it is a very hot topic nowadays about endoscopic spine surgery. I recall those days, couple of decades ago, when we started doing endoscopic spine surgery, and people are not very willing to get convinced that this is something that works. And then I am sure Dr. Manoj Sharma has got some sweet words from many of his contemporaries talking not so favorably about the utilization of endoscopic spine surgery. But we have come a long way with that. And as the wide-ranging interest we see in almost all the conferences nowadays, where most of the workshops for full endoscopy get filled very early, and there is a high demand for these workshops from time to time. And I'm sure that in today's session, we have a very good faculty here who are doing significant volumes of endoscopic spine surgery work. They'll share their knowledge with you, and I'm sure this session will be enriching for everyone. We have with us, I'll just introduce briefly all the faculty that will be talking today and sharing their rich experience. We have a very senior spine surgeon from Delhi, Dr. Manoj Sharma, who is one of the earliest ones to pick up the transforaminal endoscopic spine surgery in Delhi and the country. And he has a very large experience. And based on that experience, we have requested him to basically talk about the complication part, where the young surgeons can learn how to not do all those things that can go wrong in their early part of the surgery learning curve of the endoscopy. Then we have with us Professor Karuna Karan from Chennai. He's currently the director and of spine at MGM Healthcare at Chennai. He's an old friend and trained together in Korea long time back. He has also a rich experience of more than 2 decades of performing the full endoscopic spine procedures of all types. And we are honored to have him with us. Then we have our local guys, Dr. Ankush Girl. He is a senior surgeon and spine surgeon, and working with our team together. We work together, and he has also a reasonable experience in full endoscopic spine surgery. And then we have Dr. Nipun Bajaj, who is a fellow from Ganga Spine Hospital. And then he also worked briefly, we worked together. And now he's doing his own practice and is also doing a significant number of endoscopic spine surgeries. So that completes the faculty. And now without wasting much time, we request Dr. Karuna Karan to share with us about the evolution of the endoscopy. As I said, when we started, there was a big reluctance to acknowledge and accept it. But as time has passed, this has grown by leaps and bounds. And at the end of this session, you will realize that from where we started and where are we reaching and where are we looking forward to go further. Over to you, Dr. Karnakaran. You can share your slide and then start your presentation. Thank you.
To all of you. At the outset, I must thank Dr. Arun Banot for this good friend of mine to have introduced me to this society and giving me the opportunity to talk on this evolution and how the things have changed from the days when we started practicing endoscopic spine surgery and today where we are. And also the principles of endoscopic spine surgery we'll touch upon. So we all know that endoscopic spine surgery is basically trying to preserve the nature. So why should we preserve nature so we can enjoy full spectrum of our life so that without any causing any damage? Why this comes? See, we all know that whatever surgery for an acute disc prolapse we do, a good, well done surgery always is rewarding. So the patients are very happy. Even when we did an open laminectomy and discectomy, to today an endoscopic discectomy. The patient response, as far as the suffering is gone, they are very happy. But as doctor, we need to have certain responsibilities, like the responsibility to get them in a better level. So we always try to give them little better than what we did today. So in that context, we searched in 2000s what should be done to do it better. In that context, that context, I happened to meet Professor Dr. Gore, and he exposed me to this endoscopic philosophy. So basically, what it does is the entire erector spinae muscles, which is the most important muscle in preserving the function. If you have the good intact multifidus muscle, then the innervations to the muscles are all well preserved. Then you're going to have almost near normal function, except for the disc, which is degenerated. So the innervations are preserved, the attachments are preserved, and they say it is like a quadriceps muscle for the knee. The multifidus is going to function between the spinous process and the mammillary process. So the philosophy is, again, every tissue preserved is going to be the function preserved. So in this, then we went into doing the first endoscopic surgery. What we were taught were all through the transforaminal approach. It was when Professor Dr. Gore had introduced uh, uh, viewing the disc or the neurostructures through the transforaminal approach. There our training started with introduction of the needle. So this is the most important part of the training as far as the transforaminal approach is concerned. So we have to precisely place the needle, then and the endoscope goes and sees the structure whichever we have targeted through the needle. So this has got very little maneuverability. Initially, we found it difficult because the maneuverability was very difficult. Then over a period of time, how to maneuver and how our equipments and instruments are improved. How it improved is basically when we had a laser. Initially, we started doing with laser foraminoplasty to increase the window, which is the naturally existing foramen. So we don't have to alter any structures. Only when the narrow foramen was there, let us say at L4, L5S1, the height was less, we had to increase the intervertebral foramen where we had to use lasers. But we found that laser was very expensive tool. We couldn't invest. And as the techniques of making instruments improved, we could get more robust instruments like articulated burrs, which worked out to be more cost effective, which could be attached to our handles, and then we could do a foraminoplasty through this technique. Before we could do any sort of endoscopic procedure, the basic principle is you must not violate these basic principles. So you have to make an identification of the facet lines, and that is the maximum limit through which we can go beyond on the lateral. If you go make an entry beyond this mark, you have a chance of entering and damaging the visceral structures. This is what I meant. If your marker is just beyond the facet line, there is a chance for injuring of the visceral structures. So these principles you should not violate. And always remember, this endoscopic technique is basically to structure, is basically to visualize things very clearly. The best part of this endoscopic technique is the procedure is done under continuous saline irrigation, which makes the procedure very, very appealing and very safe. So what we found was initially, if we could have any disc between the zone 2 and zone 3, that part through a transforaminal approach is the best. But as we started getting more exposure and got more trained, we could access the zones 1, 2, 3, and 4. But there were compromise in the bony structure. So we had to drill the facet joint, and we have to remove the bony part to get the inferiorly migrated fragments. So what could have been done through a small interlaminar approach were to be a more extensive approach. The idea of doing all this had evolved because of the technology which could have. This is an oval design endoscope. It will go through a round cannula so that when the irrigation is happening, the water saline would escape through the oval part, the space between the scope and the sheath, so that there is no intra-thecal pressure because of the saline collecting there. So the size initially was started with a small 3.1 working channel. Now, most of the time we use for a transferal approach of 4.1 working channel with a continuous saline irrigation and a 25-degree angle. So we can look into different corners of the foramen and visualize structures. So earlier, we all started with doing the procedure under local anesthesia. The patient is kept awake and the procedure was done under local anesthesia. But now I have changed most of my procedures to general anesthesia because what we felt was the entire team was more comfortable. The anesthetist was calm. The operating technicians were very comfortable. When we keep the patient under local anesthesia, the patient tend to move now and then. It's difficult to communicate with them was a challenge. So now only when there is a severely compromised lung function, a cardiac function, or some issues, the anesthetists don't want to give, then we take the patient as under local anesthesia. It's a step-by-step approach. We cannot violate any step. So you have to make the markings, pass the needle to the target, and then address the pathology. So why this all started is because the transforaminal, we found that the fibrosis and scarring was very, very minimal. So that is the biggest advantage for introducing the transforaminal approach. And failed back syndrome was not there. And also the entire muscle was all well preserved. And it was truly a daycare procedure. They up in the local anesthesia, they walk out of the theater and they can get back. The rehabilitation started very early. So transforamen is totally different philosophy. Is through the natural opening of the intervertebral foramen. And it's within the foramen, you got the small dimension. Because of the small dimension, the boundaries were limited. As I said, then we have to use the burr. And you have to have the fluoroscopic guided central nucleotomy. They used to do just put an aspirator sort of a thing. It will go into the disc and do the disc decompression. It was just totally intradiscal work. It gave some relief, but when the fragment got dislodged, it could not be worked. And it was through. Then they started doing some guided fusion, and then they started doing endoscopy. It is all initially started with blind procedures. Then the camera and the visualization increased. Then the procedure became more user friendly. As I said, Hijikata and Campbell started the percutaneous fluoroscopic guided discectomy, mostly central debulking. And then Dr. Anthony Young started using the endoscopic saline irrigated continuous irrigation, non-contained disc herniations, and inside out technique was his philosophy. So what he does is goes into the disc and then starts slowly coming out, which is better control over the bleeding. Otherwise, when we did all through the epidural space, there was controlling of bleeding was a challenge. And Thomas Hoogland did started doing the foraminoplasty, where they started with mechanical handheld tools. Then they started doing the laser. Now the high-speed bursts with articulated bursts and all have started. Initially, it was only through fluoroscopic guided. Now it's through the endoscope. This was said, like the endoscopic drills have come. These are articulated, and they got a diamond burr as well as a cutting burr, and it has increased the spectrum. Like now we are able to go, if you want to have a transfemoral approach, and you can still do a transfemoral approach, and we can do the foraminoplasty. It earlier believed it's only called contained herniations. Now it's all suitable for all types of disc. It's a disc extrusion, migrated, large herniations, central, calcified, non-calcified. All these things can be done. So the paracentral disc herniation is the ideal case, where the other big advantage is whenever we see multiple discs, we can identify which is the one which is symptomatic and then target that particular disc. And you can see that after a discectomy, the entire disc is well decompressed. Large central herniations are more suitable through the transfemoral approach than the interlaminar approach. And superiorly migrated disc, I now shifted from the transfemoral to the interlaminar approach, but in the earlier days, we could still target all these superiorly migrated discs. And the current indications are any extruded disc, sequestered or migrated herniations, central, paracentral, and all contained discs can be addressed. Recurrent infectious spondylolisthesis is an excellent tool where we can have the tissue sample It is like an abscess being let out through the endoscope, and foraminal stenosis, or there is instability, we can go ahead and do a fusion. So when let it be thoracic, thoracolumbar, cervical disc. All these can be addressed through an endoscopic approach, and not only for the procedure is suitable for foraminoplasty. This is a small video where the foraminoplasty is being done to remove the disc fragment, and you can see the different instruments grow into the foraminal space to identify the fragment. And once the fragment is identified, it is slowly removed, and you can see a good dural pulsation. So what could have been a major stabilization procedure is just left with a small hole, and the entire disc fragment has come out, and you can see a well decompressed neural structure. So whenever there is extraforaminal stenosis, then you can still uh, do a discectomy, and there are recent expansions for full endoscopic resection of osteoid osteoma for thoracic spine, which was been published. And there are now the practice is the transcambin endoscopic fusions, where you can still use a curette, you can use shavers, specially designed, and you can still all do the whole procedure under complete visualization. Calcified herniations is still a challenge, but if it is symptomatic or not asymptomatic, it has to be identified, and the procedure can be executed well. The major advantage is the interlaminar technique, where you can use it as a joystick. All parts of the disc can be a disc space, the epidural space can be visualized, and that is the advantage of doing an interlaminar approach. And you can go through the small ligamentum flavum rent. If it's a crowded interlaminar window, you can use a burr to widen the window. So the out of the box ideas, there are contralateral extraforaminal endoscopy for down migrated herniations can be done, and that's the transceliac is one another technique of doing it. The take home is for each is own, and in expected hands, almost all disc herniations and some stenosis pathologies can be handled now with the technique bearing a minuscule percentage. Thank you very much.
Thank you, Dr. Karunakaran, for an excellent discourse on how the full endoscopic technique has evolved over a period of time, uh, uh, acknowledging all the pioneering work of the stalwarts who actually started this right from Hijikata and Cambion, which the people they started doing central nucleotomies, and then we started seeing the visualized pictures. And from there, now we have traveled a long way where we can actually reach almost any area within the spinal canal using the endoscope, either through the transforaminal, as you correctly said, or using the interlaminar approach. And as you showed in some of your pictures and videos, we can reach hitherto difficult areas which were not possible earlier to reach. And a lot of these cases, we are able to reduce the possibility of fusion surgeries, as you correctly mentioned. Thank you for this wonderful presentation. I request all the audience to keep writing their questions in the chat box, and we will take all the questions at the end of the talks so that we can have a comprehensive discussion. So now I invite Dr. Nipun Bajaj, who would start his talk on the full endoscopic transforaminal surgery. The principles of transforaminal surgery have been touched briefly by Dr. Karunakaran. Dr. Nipun will take it further from here, and then also talk about the technical aspects and what cases can be comfortably dealt with and which cases one should need a little bit of a constraint or a restraint. So over to Dr. Nipun.
Uh, Thank you, sir. I'm privileged to present this case, and in fact, very honored that Dr. Banot, who has been my mentor in endoscopic surgery, is now chairing this session. Sir, I would request Dr. Karunakaran to stop sharing his screen so that I can actually.
Yeah, Dr. Karunakaran, can you stop sharing your screen, please? Yeah, thank you. Okay, Nipun.
Uh, just a minute, sir. Sir, is it visible and is my audio also okay?
Your audio is
Yeah,
okay,
very
but
good.
we can't see your screen.
Okay, let me just share it again.
Pavan, what is the issue? Okay.
Sir, is my screen shared now?
Yeah. We can see you.
Okay, sir.
You're presenting it from the phone.
Yes, sir. Unfortunately, my laptop is somehow a
Okay.
virus or something, so it's running very slow. I logged in as my son's name Krishank, but still that didn't work. So I hope it is okay. It doesn't cause any trouble to
No,
every.
it's
No, it's
clearly
perfect.
okay.
It's okay.
Okay. Uh, so very good evening to all my colleagues and seniors. Uh, my topic today is transforaminal full endoscopic lumbar discectomy. Now, introduction. Basically, it uses a bypass route. It does not go through the structures, posterior structures. It uses the natural foramen, which is the neural foramen. So, direct access to the pathological site while bypassing the normal posterior bony and soft tissue structures. Now, this has the following characteristics. Application of a working channel endoscope that includes an optic system, as we all know, and a working channel, a complete percutaneous introduction with a stab incision, and a monoportal procedure, unlike the biportal procedures now being done, performed under constant saline irrigation. Now, what are the typical indications? Resection of disc herniations located in the foramen, the extraforaminal area, and the lateral recess area, ventral to the traversing nerve root. This approach is most applicable to spinal segments L2, L3 to L5S1. Although, as we heard Dr. Karunakaran earlier tell us that he has used it in segments much above that and for indications much more than simply resection of a disc, including chondroma resections and all that. Now, it also allows access to most disc herniations. Why I say most disc herniations? Because, of course, it's a learning trajectory, a learning curve where a lot of people can go ahead and do migrated discs, inferior migrated, superior migrated. But for most of the people like me, the perfect indication remains the lateral recess area, the foraminal area, and the extraforaminal area. Now, that is why I say these are all relative contraindications, except for a few absolute ones: spinal instability or a severe scoliosis. Very difficult to do because the foramen is so tight that you cannot access it. Same severe bony foraminal stenosis, the facet is very hypertrophied, although we can drill off the facet and reach the disc, but it is a tough thing to do. We can manage it by other means very easily. Location of the exiting nerve root within the inferior portion of the foramen. Now, this is a rare thing, but we must look at the foramen in the T2 weighted and the T1 weighted sagittal images of the MRI and see if the neural foramen is wide enough and if there is the nerve is actually coming out of the superior aspect, not through the inferior aspect just over the disc. I have burned my fingers in one such case where I later on realized that patient was crying in pain. I was doing it in local anesthesia. As soon as I introduced the dilator and the instances over it, and the patient was crying so much, and then I later on realized the nerve was actually lying just much below, right over the area where I was trying to access the disc. Now, as I told you, extensive migration of the disc fragment is a relative contraindication. I do not prefer doing it in that. Surgical technique, of course, the patient is position prone. It can be done under local anesthesia or conscious sedation, but usually it is better to do it under general anesthesia. Positioning, the patient is position prone either on a frame or it can be simply over a set of pillows comfortably arranged for the patient since the patient is awake, or it can also be performed on any kind of radiolucent table with the routine bolsters that we use. Rarely people do perform it on a lateral decubitus position also, but I have never tried it. Now, the plan approach, trajectory, and incision. We first of all need to take true AP and true lateral views. On the AP view, we mark the midline, we mark the pedicles, and we mark the disc space. we have to orient the AP plane trajectory parallel to the disk space. In fact, L5S1, we need to tilt it a lot. L4, L5, a little bit of tilting. So it has to be a perfect AP. We mark the AP and lateral positions. In the lateral position, we also mark the distance from the uh, midline. So typically anywhere between 10 to 12 centimeters is the incision. We have sometimes as 8 centimeters, or usually, or we may have to go as high as lateral as 13 centimeters. Just a minute. Yeah, adjust the distance to the midline by referencing to the lateral projection of the spinous process on a lateral radiograph. That can act as a starting point, and the distance usually matches around 12 centimeters or so. For a typical transforaminal approach, the skin incision is in the vicinity of the tip of the spinous process. Now, determine the craniocaudal inclination to allow a transisthmic approach to the lesion to be treated. Typically, the inclination is 20 to 30 degrees. Of course, it is a little more at L5S1, and as we go higher, it changes. The craniocaudal inclination of the approach trajectory is estimated by connecting the cranial aspect of the superior articular process and the medial aspect of the foraminal annular window, which is basically the target area. Now, how we define the target area is basically looking at the MRI wherever our disc is located. So, for most of the central discs, it has to be a much different trajectory than for the extraforaminal discs. Especially in extraforaminal discs, we tend to the nerve is actually displaced right over the disc. So target the superior part of the caudal pedicle, the lateral superior lateral aspect on an EP view. Put the needle there, put the guide wire there, dilator there, and then walk. First of all, create an annular window there, and then walk over that into the disc space. An 18 gauge needle is advanced towards the medial aspect of the foraminal annular window, the Cambian's triangle target area. Typically, the lateral aspect of the facet joint is palpated. Basically, we strike the lateral aspect of the facet joint, and the needle is then walked ventrally. You simply turn the hub to the other side and walk along the lateral aspect of the superior articular process towards the Cambian's triangle. Appropriate position of the needle tip is confirmed on AP and lateral radiographs. Now, this is the typical anatomy of the Cambian's triangle. The dark portion is the Cambian's triangle. We have an exiting nerve, we have a traversing nerve, we have the superior articular process, the superior end plate of the lower vertebra, and Cambian's triangle is basically what we are accessing. We are trying to pinpoint that area on the AP and lateral radiographs and trying to hit the center of this area. The trajectory, whether lateral to medial, it varies a little bit according to the level that we are targeting, and also varies according to the location of the target disc fragment. Then we replace the needle with a guide wire. A stab incision is made for the obturator insertion. Serial dilation using dilators of different sizes is done before the obturator insertion. Bevel-ended working sheath is inserted over the obturator. A rigid endoscope with a eccentric working channel and two irrigation channels is inserted. Now, uh, foraminoplasty, a lot of times we find stiff bony resistance when we are trying to put the endoscope or we are trying to negotiate the instruments there. So in that case, the ventral aspect of the superior articular process can be dissected, or I would say it can be trimmed a little if necessary to gain access to the lesion. Multiple burrs, handheld burrs were used earlier. Now motorized burrs are used. Direct visualization of the principal anatomic landmark, the caudal index level pedicle serves as the principal anatomic landmark. So if in case of any doubt, just put your needle or put your instrument on that and then you walk upwards and medially from that. It can easily be confirmed on the AP and lateral radiographs, mainly on the AP radiograph. Identifying the traversing nerve root. Now, it is typically dorsal and medial to the caudal pedicle, and the traversing nerve root can usually be identified, although in instances where there's a lot of bleeding or the anatomy is not very well defined, visualization can be an issue. But in most of the cases, we can visualize it. If it cannot be visualized, then we have to judge or estimate the location of the nerve root and try to try not to injure them. The disk sequester or the disk fragment is usually visible because we are sitting right on top of that, mobilized with either a radio frequency probe. Basically, annulotomy is done, and resected using a grasping forceps, then visually confirm to the decompression of the neural elements, even if the uh, nerves, the traversing nerve is not visible at the start of the procedure. Usually when we remove the fragment, we can safely see the nerve. So this is just a, sorry, just a minute. Now, what are the complications? We can, of course, encounter the same set of complication as with any other form of discectomy. It is intraoperative dural tears. They're usually very difficult to detect because of the constant saline irrigation and are difficult to treat also through this approach. Recurrent or retained disc fragments, inadequate foraminoplasty, post-operative paresthesias, pain deficits are rare, but possible intraoperative irritation of the exiting nerve root can lead to it. Typically treated by NSAIDs, gabapentin, and sometimes we also inject transforaminal steroid. Typically, as Dr. Banot used to say, if we see a very inflamed nerve root, it is quite red and angry looking, we will put some steroid on top of it. Infections can happen and hematomas can form. Now, post-operative care, basically the patient is discharged either on the same day or the next day, as Dr. Karunakaran said. It is a very commonly done daycare procedure, or at the most we make the patient stay for 28, 24 hours. Sometimes for the patient comfort and sometimes for the financial reasons that a lot of companies, insurance companies will not pay up if the patient is not there for 24 to 48 hours. Now, in routine follow-up, if we find that the results are suboptimal, the patient continues to have pain, then we must do a MRI immediately and take corrective actions right away. In most of the cases, I remember Dr. Brunot used to get the MRI done on the next day as a mandate. Every case we do, the MRI will be done either on the same day later or the next day. Now, what are the keys to success? The initial approach should be conducted under the lateral fluoroscopic projection rather than EP. Yes, of course, both the approaches are required. The needle tip should slide from the lateral surface of the superior articular process into the foramen. Anatomical layers or strata, including the dural sac, the nerve root, which is either compressed or adhered, surrounding epidural fat, congested annulus, and the herniated nucleus should be confirmed. So, anatomy is the key to success. Careful anchorage of the disc to the annulus should be released before removal. Now, that is a mistake that I personally made, and a lot of juniors now I see making. Uh, Go in straight away for removal of the disc fragment. We confirm our location, we are there, everything is done nicely. But if it is a contained disc, the annulus has to be cut first, just like in any discectomy. So his role is done by the radiofrequency coagulation probe or anything. Make a reasonably sized access to the disc and then remove it. Outcomes have been compared since times immemorial. The earlier studies conducted in 2008 to 2015, 2020, wherein transforaminal endoscopy was the what you call the blue-eyed boy. Now there has been a lot of shift towards interlaminar, and personally, I have also discussed with a lot of people. Significant number of cases are now being dealt with this interlaminar endoscopic discectomy. But yes, this is a very good tool to have in your armamentarium, especially for the lateral, the foraminal, and the extraforaminal discs. For 2-year follow-up, both the groups experienced similar improvements in pain and function. A statistically significant number of patients in the microsurgical group experienced greater back pain postoperatively because we had to remove more structures. There were no significant differences in the reoperation rates, and the endoscopy cohort was found to have statistically significantly with fewer complications, less postoperative pain medication requirements. So it suggested that this, but nowadays, what we find practically is that a lot of patients can have to go back to their previous employment, previous work very early, and they're very comfortable with a transforaminal procedure, much more comfortable than they are with the interlaminar procedure. So again, conclusions, functional improvements were maintained at 2 years in both groups with the ongoing sciatica after transforaminal endoscopic discectomy. I think I will stop at that, sir. We have some more studies lined up, basically saying that the transforaminal procedures are at par and in some cases better in trained hands.
Thank you, Nipun. Sorry, I was muted. So, thank you for this wonderful uh, description of the transforaminal approach. Transforaminal is the cornerstone of full endoscopic spine surgery. As Dr. Karunakaran said, that for the first few decades, it was only transforaminal full endoscopy that was in vogue. And then the need for interlaminar approach was felt, and then interlaminar approach was brought in. And now, because there is a versatility of these two approaches, a lot of surgeries now are being done with the use of the full endoscopic system, as we continue to see from each presentation one after the another. Now I invite Dr. Ankush Garg. As I said, he is a part of our team, and he is a proficient endoscopic surgeon, to share his experience and tell us about the interlaminar approach for full endoscopic spine surgery. Over to Ankush. Ankush, you are muted. You have to unmute yourself.
Is my screen visible now, sir?
No, your audio is now, yeah. Yes. Now it is visible. You can start playing this.
So thank you very much, Dr. Bhanot. And Nipun gave a broad, after Dr. Karnakar, Nipun gave a broad presentation about the transforaminal. Now I'll start. What is the difference between conventional microscope tube assisted and UV? In all these surgeries, we usually need to excise ligamentum flavum
The
and
slides are not moving, Ankush. Can you just run it in a slideshow mode? Only the first slide is being seen.
just a moment. I'll start. I'll try to share again. Sorry.
Yeah, it's okay.
Is it moving now, sir?
No.
No, sir.
Yeah. Now it is. Now it is gone to the second. Are you presenting from the PPT window only, or as a slideshow? Can you just go to the slideshow so that you have a full screen?
Sir, please stop share, sir.
Pardon?
Stop share, sir.
Okay.
Ankush, can you just stop sharing once again?
Yeah. Click on sir share screen and select sir entire screen, sir.
Yeah.
Select entire screen, sir, and then share, sir.
When you share screen, then pick up the option of entire screen.
Yes, and then share, sir.
Is it okay now?
We can see the second slide.
Yeah, now it's second slide, sir.
Yeah.
Sorry. So when we do all these conventional open microscopic tube assisted or UV surgery, we have to excise whole of the ligamentum flavum and neural structures have to be retracted. While full endoscopic surgery creates a small opening in the ligamentum flavum, I'm talking about interlaminar, and there is least collateral damage. So we use a rigid working channel endoscope. There is no separate portal. The optics are excellent.
The slide has still not moved, Ankush. Yeah, now it's it.
Now it's moving, sir.
Yes.
So we use saline medium and optics are excellent. The indication, as Dr. Nipun also shared, and transfemoral discectomies are excellent tool, but sometimes we get stuck, like down migrated herniation because of hypertrophied ascending facet, lateral edge of ligamentum flavum, and upper edge of inferior pedicle. Similarly, in up migrated herniation, foraminal ligament, lateral edge of ligamentum flavum do obstruct us our approach. Then foramen size and location, alpha S1 with a high iliac crest, up migrated disc, as I said, and degenerated disc in cases of foraminal stenosis. Lateral recess stenosis, we cannot do it with the transforaminal alone, especially if it is bilateral. So that can be done by interlaminar approach. And as Dr. Karunakaran also mentioned, calcified disc are better handled with this approach. And to start with the technique itself, full endoscopic spine surgery, interlaminar spine surgery it's a fully mobile system. Cannula doesn't need to be fixed like transforaminal, and it allows wider inspection of the operative field. And endoscope can be advanced further anteriorly to look under the nerve root and even the thecal sac. So in this slide, we can see the vision. If we see microscopic vision, it's a tubular vision. If we have to look in this area, we have to excise a lot of bone. But with a endoscope, we can look into the corners under the nerve, and the magnification is quite big. Compared to microscopic view, because of the saline and the proximity of the scope, the structures are beautifully seen. And it is all done by a 8 mm incision if we are doing through 3.5 mm scope. The patient is position prone. For the discectomy purposes, we do break the table to open up the interlaminar space, but in cases of foraminal stenosis and stenosis, it is not advised to open the interlaminar window. The target is the inferior edge of the superior lamina, as marked here, this here, and laminofacetal junction where it's crossing the disc space is our entry point. The cannula is placed over the cannula, working channel is placed, but obturator and cannula are placed, position is checked, and this is how we insert the. Is the video moving, sir?
No, you have to click on that video. You're still in the non presentation mode. This particular thing is not working. Your animations are also.
Is it now?
No. No problem. You can play the video from this window itself if it is. Yeah, you can click on this.
So then the cannula is inserted with the bevel facing medially to start with, and then we can start introducing our instruments and do all the steps. This is a picture to show how to hold the scope. It's with your shoulder down, relaxed elbows. Now I'll start with this is a right-sided paracentral herniation. Once we go with a scope, first thing we see is the muscles. With the grasping forceps, we clear it and expose the ligamentum flavum. As the ligamentum flavum is exposed during all these steps, we keep on getting the hemostasis done. And once the ligamentum flavum is exposed, we start cutting with this endoscopic cutters. It's a beautiful instrument with two tongues. One is rigid and longer. The other one is slightly smaller, and it cuts safely, slow. Once we go in, we start to see the difference of color in the ligament. And once we are in, we can see we have to expose the lateral edge of the root, and we retract it gently and cannulized. I'll play it again. Sorry, it was too quick. So once we displace the nerve gently, we don't retract it. We just mobilize it, advance the cannula and rotate it. The bevel now faces laterally so that the neural structures are medial. And then with the same cutter, we make a small opening into the and grasp the small and large herniated fragment, and we can see the inflamed nerve root as Dr. Nipun just mentioned. And once we come out, we see the small opening in the ligament. It's hardly less than 2 mm opening is made into the ligamentum flavum. This is another video to show how to with the rod just decompress the lateral part of it, retract the mobilize the nerve, retract the cannula, coagulate the disc surface, and make a small opening with the cutter, and we can take out several small and large fragments through the small window. You see, it was almost 4.5 centimeter long disc fragment. Then we usually install little steroid in most of the cases, and then we go on to explode through axilla. This way we can go right up to the midline and maybe beyond also sometimes. Then another indication, calcified disc. I'll show you the example. It's a 43-year-old male doctor he's an active sportsman. He had a left foot weakness. We can see here that this calcified, it's basically acute on chronic disc. So once we go in, same steps are followed. Once we rotate the cannula and expose the hump, first we remove the acute fragment. You see, this fragment is lying along the hump. We remove it, then we coagulate the surface of the hump, and with the face mill and small chisel and osteotome, we free the calcified disc fragment, I can say, and just we continue to remove it. So this is the post of MRI of the same patient. Similarly, we can apply this to a grade 1 relative stable listhesis with stenosis and maybe a facetal cyst also. This is the post of MRI. You can see the widely open space. This is for the comparisons. At the same place, pre-op and post-op pictures, we see nicely expanded thecal sac, and the ligamentum flavum is completely removed. So this would be my last slide. See, all those microscopic or earlier endoscopic assisted procedure, they had a small skin incision, they have small skin incision. There is a less collateral tissue damage. There is a good vision inside the field. There is a better protection of nerve tissue, and it is widely applicable in many types of indication. But with full endoscopic procedures, we have the smallest of all skin incisions. There is the least collateral tissue damage. There is excellent vision inside the field, the best protection of nerve tissue because we just rotate the cannula through the window which is already there, just by making a small slit into the ligamentum flavum, and it has a very wide application than earlier. Thank you, sir.
Thank you, Ankush. That was an excellent presentation on the technical aspects of the interlaminar technique, as well as you also mentioned very nicely the optics difference between all other visualization symptoms. So, for the audience, this is the major difference, that as your scope is giving you pictures very close to the neural structures that you are working upon, and there is a constant saline irrigation, so you get to see the anatomical structures in their natural habitat as they naturally exist in the spine. So there is no undue reddish hue, which, or you have to constantly, there's no need to constantly keep using the sucker to suck the blood and keep it out of your blocking the vision. So that job is already being taken care by constant saline irrigation. And the videos that you showed, they were very clear in showing this difference. Thank you for this wonderful presentation. And we will take the questions, as I already said in the end. Now I invite our senior most faculty member from Delhi, Dr. Manoj Sharma, who will be sharing his rich experience of many years of full endoscopic surgery and guide all the youngsters that how one can avoid landing up in mistakes and then avoid these complications. Dr. Sharma, please.
Yeah. So is it okay? Can you hear me?
Yes, sir. Very nice.
Thank you. Complications and avoidance. This is the most important thing. I don't believe in hope. I believe in action. If I'm an apostle of anything, means if I want to do something great, there are always going to be complications, but to a large degree, everything is in your hand. Means you can prevent them. You just have to learn it. And just a bit. How do I remove this side? Oh, I'm sorry. Just a bit. I'm sorry. I'm sharing it again. When I share it, actually, Banot, your name is coming there. When I share, now, when I double click, your name comes there. So what to do?
But I'm not hearing anything, sir.
Again, just okay. So I go here, I think. No. Yes. I think this should be okay. There is some problem when I share. Arun, your name comes there.
Can you unshare and share again? Stop sharing first.
Huh?
First, you stop sharing.
Yeah, I've stopped sharing and it shows share down there. But when I touch it, your name is coming there on the screen.
Pavan, can you look into the matter?
Yes, sir. I'll ask this tech support is.
Yeah, please.
Arvind.
So first you go out of the PowerPoint presentation mode, come to the normal window, because you are still in the PowerPoint mode.
So you want me to go out?
Yeah.
You are screen sharing. Stop share. Okay, I've stopped share now.
Yes. So now again, See,
Now
there is
I
nobody
share.
sharing. So now you share again.
Now I share again,
Share full
and
screen.
now, oh, this. So on the right hand side, actually, how to, because I am not able to see the right side of my screen because the names are coming here.
That's okay. There's no need. So you can just continue to leave those names there. You just play the PowerPoint. Yeah. Now it's working fine, sir.
Okay, great. So what I was saying was that to be successful now, because my screen, I cannot read on the right side of my screen. Just a minute. Yes, now of course I can. Uh, Okay, so to be a successful surgeon, you need to have the eye of a hawk, the heart of a lion, and the hands of a lady. In the morning when I go for the morning walk, often I come across a very strong built young Hulk. He is about 45 years of age. And about 25 years back, I know, and he walks with a little limp. 25 years back, I had operated him for an extruded disc at L45, and the next morning he had a foot drop. And 25 years down the line, when I meet him, and especially when he greets me with the affinity, the respect and love, that sinks my heart. I go into sorrow, and that's a kind of remorse feeling and repentance which I feel. There is a share which says that तमाम उम्र मेरा दम इसी धुएं में घुटा, वो एक चिराग था, मैंने उसे बुझाया है. So anyway, now there can be three things. Failure is when objective of the procedure is not met. Sequelae is a known after effect inherent to the procedure. Complications are the untoward incident that lead to deviation from the ideal course of management, which impairs and delays the recovery. Lumbar disc herniation is one of the most common pathologies. The paradigm is shifting towards the endoscopic management. Technical and instrument evolution now enables endoscopic decompression of nearly all types of discal pathologies like complex stenosis, fusion, infection, tumors, thereby bringing in risk of more complications. Most of the complications are not different from the other spine surgeries. TELD, or the transforaminal endoscopic lumbar discectomy, also has its own sets of complications due to different approach, different structures, instrument, and the fluid media. The commonest complications are the dural tear, recurrence, nerve injury, postoperative diastasis, vascular injury, broken instrument, hematoma, infection, incomplete removal. In a multicentric study of about 26,000 cases, the overall complication rate of the TELD was less than 1%. So we should be happy. The diaesthesia was about 0.45%. The CSF leak was 0.17%. The discitis, the motor sensory loss, and the recurrence was also very less. So we are classifying the complications based on the timeline and the technique. Now, intraoperative complications approach related can be when we are approaching the disc. Now, the number one is the pain, and this can be because of the irritation of the exiting nerve root causing the root pain. So what we have to do is that because we know in the upper part of the foramen is the exiting root, so we have to try to land into the lower part of it. So our needle should follow the lower part or the caudal part of the foramen, and or else we have to be a little back. So we have to walk down the facet. So we first hit the facet, and then we just slide our needle in, and so we can prevent touching the exiting root. The use of the sequential dilator is another way to do it. And we should at all times try to avoid the root manipulation when we are inside. So, but still, if the patient is anxious and uncooperative, then we must convert the case to general anesthesia. Vascular injury is a bleeding due to injury to the vascular structures can be challenging, and it can be because of the epidural vessels, the foraminal artery, segmental lumbar artery, or the great vessels even. So what can help us is the bipolar and RF ablation, or we can do the pressure saline, which can improve the visibility. Reinsertion and holding of the trocar for some time, that can tamponade. Cold saline and adrenaline in the saline irrigation will also help. Visceral injury, the abdominal and retroperitoneal structures may be injured if the skin entry point is too far lateral, and like if you are approaching a central disc, and with a lower angle entry. And the trajectory, and this can happen even if it is too much vertical, because we can go down by the side of the body anteriorly. So the instrument can reach beyond the anterior annulus in the spondylodiscitis case, because the disc is very soft, it's all pus and soft thing. So we can even, and the anterior annulus is also soft, so we can go anteriorly, and it can be disastrous. So we must repeatedly confirm the instruments on the fluoroscopy, AP, and lateral view all the time. Now, wrong level surgery, this is the worst mistake, but unfortunately common. So confirmation of the correct level repeatedly, presence of the transitional vertebra or a variation in the number of vertebrae may cause confusion with the MRI picture, because it may not match with your C-arm picture. So you must look at everything, like the height of the disc, the osteophyte, the shape of the bone. Like S1 you will find is a longer and it is an oblique bone. So considering everything, you must go, because your aim is to go into the perfect level. Now, surgery-related complications can be the dural injury, dural breach, or the root sleeve injury is not a rare incidence. 1.8 to 17.4%. Most dural tears are self-sealing due to tamponade effect. But if the surgical objective is already achieved, then we can just observe the patient. But if the objective is not achieved, then we have to go in by the open exploration, and we must achieve that, and we should repair the sleeve, this breach as well. Now, nerve root strangulation into this small hole in the dura can cause a radicular pain. We must go for the open exploration and repair. Packing of the area, sometimes the leak is unnoticed. The packing of the area with Surgisil or gelatin sponges bit may be successful. Advisors always work in the full visibility, no fishing in the dark. Never try to grab anything which you can't see. And if there is bleeding, you must control that first. So in the spine, the first principle is the visibility. Never work in dark, or when you are, you abandon the procedure. That is better than working further. Now, neurological injury, all the neural structures are at risk: the traversing root, the exiting root, DRG, furcal nerves. Now, needle target, as I just said, should be in the lower half of the foramen. The cannula bevel, when you are taking over the obturator or the dilator, when you are taking your cannula inside, its bevel or its opening should be superiorly towards the root or exiting root, so that the leading edge doesn't press it. And when you have entered inside the disc, then you can, you can turn it dorsally. So that's an important step. And then in the MRI, you must always detect a low exiting nerve root. If that is the case, you have to be extremely careful. An articulating instrument, especially when they go up, at times you cannot see the tip of that instrument. So do not grab anything with that tip. You might grab the dura or anything else. Now, instrument failure, because instruments here are thin, they are low profile, delicate, and they have very long lever arms. So the chances of the breaking are more. So what you have to do is you have to care them in a very gentle way. And the surgeon, if you want to joystick, if you want to move around, do not do it with the instrument. Do it with a working cannula. Iatrogenic bony injury and stability. This is if you do an over-enthusiastic bony work, but we don't do it in endoscopic much. So I think this is a rare complications. Failure in the missed fragment. The patient will have a radicular pain without significant pain-free interval, because initially for a day or two, because of the local anesthetic, he might feel he's okay, but on the third day, he'll start having pain. It can be because of a migrated disc, axillary fragment, or the large central disc. Immediate preoperative screening of MRI. At times we see an MRI which is about 6 months old or 7 months old, and we operate on that. But there might be a lot of changes. So, I mean, instead of feeling sorry later on, it's better to do an immediate pre-op MRI. A concomitant lateral recess stenosis can also cause the pain. So, if there is an associated stenosis, we must at the same time address that. So, ability to recognize the end point of the decompression is the key. Seizures. Intraoperative seizures are due to the increased epidural pressure because of the constant irrigation. So, and this can happen if there is a fast speed of saline infusion, there's a prolonged, I mean, duration of surgery. The manual irrigation is always better than the mechanical one, over which you don't have a control. The high index of suspicion and early recognition, like the neck pain, headache, confusion, is the key to avoid seizure. Anesthetic relation, I think this is not an important thing. This is the anesthetic topic. So, the post-operative complication, the most common is the post-operative dysesthesia. Now, dysesthesia is a very unpleasant and abnormal sensation, and this is typically seen when you burn or when you irritate the DRG. This can be because of the irritation of the exiting nerve root, DRG, focal nerve, or the traversing nerve. The injury can be caused by the needle or obturator, the working cannula instrument, or RF cautery. The patient has an unpleasant sensation called the postoperative dysesthesia, POD, and can be up to 15% of cases, but it recovers within weeks or months. But at times it may be troublesome and it is a different pain. Patient might be after your skin. The risk factor are the foraminal of far lateral disc, the narrow foramen, blind reamed foraminoplasty, blind. You're not looking, you're just doing it blind. So you can damage the nerves. And the fusion indication, because there you use lots of instrument and you can manipulate the nerve. So fusion with expandable cage. Postoperative pain can be because of lots of things. The residual disc fragment, which can be because of an axillary disc or a calcified disc, or it is combined with the stenosis, which you have not taken care of. De novo disc prolapse is an iatrogenic disc, which happens by hammering the trocar, and you produce a new disc which comes out. So, but the prevalence is very less. The nerve root edema, we all know, will happen. Herniated rootlet, we have already spoken about. Iatrogenic segmental instability is not very common. We just spoken about it. Epidural and retroperitoneal hematoma. It can be because of the segmental artery or the lumbar radicular artery can cause this retroperitoneal hematoma, or epidural hematoma can develop because of the venous plexus epidural or the foraminal vessels. Now, the incidence is very low, and the revision surgery may be needed in very, very few cases. Anticoagulant must be stopped 3 days prior, and we must achieve a complete epidural space hemostasis before we close it. And a misdiagnosed hip, knee, and peripheral nerve pathology is another thing if the patient is not improving. Now, neurological deficit, I've just spoken, it's a rare thing. Extravasation of the irrigation fluid is possible because it's a fluid medium-based surgery, and the fluid can seep into the tissue plane. It's about 3.8%, but it's a self-limiting thing. Pneumocephalus is an air enter into the subdural or subarachnoid space, very, very rare. It's an anesthetist job. Ecchymosis, lumbar segmental artery pseudoaneurysm, superficial wound infection, systemic complications like DVT or PE. Radiation hazard, that 2.5 minutes every case has been used. So you can, in a year, you can do about 5,000 TELD. I think that is enough. Discal pseudocyst, very, very rare. Now, late complication can be spondylodiscitis. This can be because of the puncture of the intestine during the needle insertion. When you insert the needle and it's gone through the intestine, it gets infected and it can contaminate the disc. And we will know it when the patient after a week comes back to you with back pain and fever and all that. So we know how to treat the spondylodiscitis. Initially, we give 6 weeks of IV antibiotics and rest and braces. And then if it doesn't improve, then with the With this endoscope, we go and do the debridement, and if nothing works, then of course we do an open debridement with the interbody fusion. Similarly, psoas abscess, the similar kind of etiology, an inadvertent puncture of the intestine during needle insertion may lead to the psoas abscess as well. The treatment is more or less the same. Now, recurrence of the same side or the contralateral side. The cutoff time of the symptom-free period has always been a debate. Is it 2 weeks or up to 6 months? But now they say that early recurrence is before 6 months and the late is after 6 months. The recurrence rate is similar to the microdiscectomy, about 3.4%. And this can happen. The risk factor are insufficient decompression, increased high disc height, early and strenuous post-operative exercises, demotic changes, and all that. Epidural fibrosis and scarring is very, very rare, but it can happen if you excise too much of annulus and PLL and the flavor. You may have to go for re-exploration. Thank you very much. You see the surgeons and patients and NSH, all are happy in this picture. Thank you very much.
Thank you, Dr. Sharma. That was really the pearls of wisdom talk. And I'm sure a lot of questions that the audience might be having regarding the endoscopy, etc., have already been answered by you in your extensive discourse about all the problems that one can anticipate and their remedial measures as well.
Thank you.
Thank you. And now the onus is on me. I have to present the final talk about where are we now about as far as the journey of endoscopic spine surgery is concerned. Is my screen visible to all?
Yeah.
So we have had an excellent description about how the journey of full endoscopic spine surgery started. Then Dr. Nipun took us through the transforaminal approach and its intricacies, and he also shared his personal experience of how he erred in his earlier cases, and that is a lesson to be learned for all the people who are contemplating their journey towards full endoscopy, that one should be patient and one should be perseverant to continue to carrying on these approaches. So the full endoscopic spine surgery, where are we placed now from the time that it started, and what do we look forward towards the future for the scope of the full endoscopic spine surgery? And my statement here is that there is ever expanding scope for the endoscope as far as spine surgery is concerned. And in the slides that I'm sharing with you in the next 10 minutes, I hope that we can come to a mutual agreement on this particular statement. So I'm just sharing a few cases, videos to show the application of this, starting from the bare minimum basic. This is a standard transforaminal approach for full endoscopic spine surgery for a paracentral herniation. So you can visualize the structures so nicely. You can coagulate them. Now we are cutting the PLL, and the moment we cut the PLL, we can see the disc fragment. So this is the difference between conventional surgery. You first see the pathology, then you remove it. And the moment you remove the herniation, you see a little bit of bleeding, and then you visualize the decompressed traversing nerve root. And that is the end point of your procedure. In normal cases, where you have a paracentral herniation, usually this takes just about 20 minutes only to reach this decompression level. Then high migrated herniations have been hitherto considered not very suitable, as Dr. Karnakaran said, that they required a lot of bone drilling in the beginning. And we also used to do that earlier, but nowadays we do carry out an approach, something which is called as a translaminar. So here you see this is a L3-4 herniation going beyond the zone 1. Zone 1 is a high migrated zone. And you can see this herniation has gone above the upper border of the upper pedicle at that level. So this is where it is. And what we do in this case, not the transforaminal approach, not the interlaminar approach, we just do the translaminar approach, because in the interlaminar approach, we would have to drill a lot of the lamina to reach the herniated fragment, which is close to the pedicle and above. So instead, what we we can see this is the decompressed axilla as well as the exiting nerve root in this case. And this is the post-operative MRI. We can see very nicely everything is decompressed. And through this tiny hole, which is on the reconstructed CT, and you see there is no violation of the ligamentum flavum. We have not done any laminectomy. And this hole, as we orthopedic surgeon, we know it is going to get filled in due course of time. Then this upper lumbar thoracic herniation, this case was shared by Dr. Karnakaran earlier as well. So I am going to skip the video part and just showing how this kind of down migrated herniation. Why we don't use the interlaminar here? Because it is L1-2. So manipulation of the spinal cord here is going to be difficult. And that is why transforaminal approach is preferred in these cases where this, you can see this is again zone 4 down migrated herniation. So by I'll skip the video as it has already been shown. So you can see this is a fully decompressed, and this is the final picture. Now, dorsal calcified herniations can also now be treated using the transforaminal approach. This is a D910 disc herniation. You can see there is an indentation of the spinal cord by the herniated disc, which has got calcified over a period of years. I have been treating this patient conservatively for more than before we had to undertake this surgery for her. So in this case, we dock the cannula onto the lateral edge of the facet, and then we do that foraminoplasty by drilling the undersurface of the facet. So the video is going to start where partial drilling of the undersurface of the facet has already been done, and then we advance the drilling further to reach the medial edge of the facet. In this case, we also do a special thing called as lowering of the floor. So we are opening the medial open edge of the foramen by cutting open the ligamentum flavum, and then we drill a part of the posterior surface of the vertebral body. So that will allow the cannula to shift anteriorly. So now we can see that without violating the epidural area, we can visualize this hump, which was the scene on the MRI. So this is the disc osteophyte hump, which we drill and from the below. And then by using various instruments like endoscopic chisel, endoscopic drill, we keep thinning it, and then we keep removing the undersurface of the this bony hump first. And once we have made it hollow by repeated drilling, by repeated use of the chisel, as I'm showing multiple times, there's no need to hurry. Keep going slow with patience because we are dealing with thoracic spine. So you can see we can go right across and up to the other side. So by this, we thin the bony hump and we removed it. And as we have removed the bony hump, we also use this articulating curette to mobilize the fragment into the hole that we have created. And now we can visualize the anterior surface of the dural tube. This is the PLL being cut. Now the thin sliver of the bone, which is left, can be easily separated from the dura and then brought into the bony hole that we created in the vertebral body. And now we can grasp it and take it out. So at the end, we can visualize the exiting nerve root, and now we see the anterior and lateral surface of the fully decompressed dura. So this can be done through the transforaminal approach. You can see this is the fully decompressed MRI here. Without hardly minor small residual osteophyte is still there. We can also use the full endoscopic interlaminar technique for doing cervical disc decompressions. Nowadays, we can also do stenosis surgery, but this video I'm just showing for the sake of completion, the application of this technique for a cervical radiculopathy. Now we can see there is a large paracentral C6-7 herniation, which we are doing through the interlaminar approach, cervical interlaminar approach. So in this case, we mark the space with the needle, and then we create a window by dilator. We dock the dilator onto the bone, and now we introduce the scope. We clear the interlaminar window with the endoscopic forceps as well as the flexible bipolar and identify this V between the two lamina. Then we start drilling the lower edge of the upper lamina from the middle, and then we proceed laterally to the medial edge of the facet. And from there, we proceed distally to the upper edge of the lower lamina. So we can, as we drill, we can visualize the attachment of the ligamentum flavum to the undersurface of the lamina. Once we see this attachment, we start removing the ligamentum flavum and by using the endoscopic kerrison as well as by the endoscopic grasper, and then we see the lateral edge of the dura. Now the next step would be to identify the exiting nerve root here. So the exiting nerve root is now seen. We expose it and we can see that the exiting nerve root is pushed and tented by the herniated mass. So once these two structures are identified, we mobilize the herniated fragment with the endoscopic hook, and the multi-fragmented herniation is gradually being removed one by one. And then when we remove the last fragments, we can see some bleeding. We check for remaining fragment on the upper edge of the nerve root, and we find one which is again removed and after mobilization. At the end, we see a nicely decompressed nerve root, and this is the post-op MRI. It's all done through this small tiny hole of 8 millimeter. Even the thoracic giant herniations like this, you see, this is again a D9-10 herniation in a crooked spine. The patient had a tubercular spine in childhood, but he was doing his living comfortably till he presented with myelopathy due to this new herniation in his 60s. So you can see there is a large herniation, giant herniation, what is described in thoracic spine herniation many a times, multifragmented, which is displacing, which is occupying more than 50% of the spinal canal, bony spinal canal, and displacing the spinal cord to the left side. So even these herniations can be safely removed again using the transforaminal approach, doing the foraminoplasty, and you can see there is complete resolution of the giant herniation as well, and the patient gets relieved from myelopathy. You can also deploy the full endoscopic technique for decompression of lumbar stenosis. Ankush has already shown one slide, and I am showing another case where you can see the intraoperative CMs show that how much is the extent to which we can use the endoscope. So we can do from the upper pedicle to the lower pedicle, and we can use the endoscope from one side and go right across the other side up to the medial edge of the other pedicle. And sometimes we can also decompress the upper exiting nerve root of that segment if that is also perceived to be contributing towards the symptoms. So this is the post-op MRI of the same patient. You can see there's very nicely decompressed thecal sac at the index level. This is a small video demonstration of how the stenosis surgery is done. We open up the interlaminar window, then we start drilling from the facet, medial edge of the facet, go along the upper lamina and expose the origin of the ligamentum flavum under the lamina. And then we start separating first from the upper side where it is going under the upper lamina, then the medial side. This is the lower separation. And once the lower edge is separated, then we also separate the ligamentum flavum from the lateral side, from the medial edge of the facet. So by mobilizing the flavum, we can remove it in one single piece. So this is not ego trip, but removing it in one single piece makes sense because it allows neural protection while you are manipulating your instrument. So then we can also do the same procedure on the opposite side by drilling and then removing that part from the other side. So this is how at the end we will see the ipsilateral nerve root is fully decompressed, thecal sac is decompressed, and the other side of the area, which is also showing the contralateral traversing nerve root, is fully decompressed without any residual pressure. So this is what they commonly call the butterfly challenge, where they intend to remove the whole ligamentum flavum in one go, either in one or two pieces. Here you can also do the same through the full endoscopic technique. So can we do fusions? Yes. So in this case, you see there is a L4-5 degenerative listhesis with a facet cyst on the right side causing right radicular pain, and patient also had back pain. So that the reason is that we can see some instability at L4-5. So this case requires a fusion surgery because of the instability and the need for removing the facet cyst. Many a times, if you just excise the cyst, that it can recur. So that is why we sometimes have to choose a fusion surgery in such cases. Not all the time, but yes, some cases. So we dock the cannula, and now we identify the lamina and the descending facet. So we do the facetectomy of the descending facet first, just like we do in our mini T-lifts. We can also do this with the burr, but then we will lose the important bone graft. We can also remove the facet in one piece or by multiple pieces. Multiple pieces it's a bit easier without needing to create a big skin incision. You can remove multiple bony pieces. Sometimes we also remove it through the single incision by widening it. So once you have removed the descending facet after doing osteotomy, you identify the medial edge of the ascending facet. So you clear that, and then you also osteotomize the superior part of the superior articular process. Once that is removed, then you can remove the ligamentum flavum and identify the lateral edge of the dura and the traversing nerve root. The interlevel cleft in the midline is seen. From there, we remove the flavum on the ipsilateral side. This is a blood vessel which we will shrink and remove. And then we identify the lateral edge of the thecal sac and the traversing nerve root, which is then mobilized and retracted. We can use this small retractor, which can be introduced through the working channel. And we can use this to protect the nerve root medially and open the disc space and prepare the disc space under endoscopic visualization. Once that is done, we can use the semilunar retractor and prepare the disc space under fluoroscopic control and introduce the cage and check the position of the cage like this. And once this is confirmed, then we can do the other side decompression. And from there, then we can go on to put the pedicle screws and secure the fixation like this. So this is the endoscopic fusion can be done. Now, this is not my own video. I have taken it from YouTube, courtesy of Dr. Paul Hall from Germany, just to tell that what full endoscopic surgery spectrum can be achieved nowadays. So one can also start using the full endoscopic technique for removing even intradural tumors. So as you see in this video, the cannula, this is the stenoscope which is used to open. First, we open the dura, and then the tumor is identified, cranial and caudal ends are mobilized. And once they are mobilized, one can grasp the tumor and gently mobilize it through the fascicular bundles of the nerve roots floating in the intradural space, and then gradually debulk it. And then you can identify through high magnification the fascicles which are connecting it to the nerve bundle, and then release the tumor and remove it. Once you remove it, you can see this is a complete removal of the tumor can be achieved. The nerve root which is coming out of the dural opening can be positioned again, and then you can do the dural closure by dural suturing again through the full endoscopic technique. So all this can be achieved nowadays with the full endoscopic technique. So to conclude, the advanced tools and the good understanding of the pathological lesions with good adequate experience, surgical tools and training, many of the earlier contraindications, which I myself used to say that these are not indicated a couple of decades ago, now we are able to treat those pathologies very comfortably using the full endoscopic technique and in a much better way, because you have seen how good the vision is. And as Dr. Sharma mentioned clearly, visibility is the key to success of any good surgical treatment. And we can achieve that visibility very comfortably. So to summarize, currently we can treat stenosis, one or more level. We can treat cervical decompression, including discectomy and stenosis-related myelopathy. We can do fusions. We can also remove intradural tumors. We can excise thoracic disc herniations, which could be giant as well as calcified. And as I said, intradural tumors. So what does the literature say? As Nipun had mentioned a few papers earlier, I will just conclude by showing this simple one meta-analysis that earlier the advent of newer techniques offered alternatives that intuitively seemed better, but they did not have literature backing because literature was not written. This was being created. But over a period of time, several literature studies are now being published to substantiate the initial intuitive advantages of full endoscopic spine surgery. So I'm citing this meta-analysis involving 27 studies involving more than 4,000 patients with 11 RCTs included in this. Their conclusion was that as far as a full endoscopic surgeries for discectomy is concerned, though it may sound similar to microdiscectomy on 3 parameters of pain score reduction, recurrence and reoperation rates, and return to work. Here it is important to understand that many times I get to hear this question, are recurrence rates higher with endoscopy? But or large experience of several centers proves that recurrence rates are similar with endoscopic and microscopy. In fact, my position statement is that they are patient dependent rather than technique dependent. However, the endoscopic techniques is considered superior as far as functional outcome is concerned, especially the ODIs. Duration of surgeries are usually smaller and length of hospital stays even smaller. So, finally, full endoscopic spine surgery. We have me, Dr. Sharma, and some of Dr. Karunakaran. We have seen the evolution of endoscopic spine surgery in this country right from its earlier days, and we feel that this journey has rather just started, and there is miles to go before it reaches its designated place in the realm of spine surgery. Thank you so much for this patient hearing.
Very good talk, Dr. Arun.
Thank you, sir. I'll stop sharing and then we can go on to. So my share is already stopped. Now we are open to. Can we come? Can we ask all the faculty to start their video feeds? Yeah, Dr. Karunakaran, Nipun, Dr. Sharma, please.
Yeah.
So do we have any questions from the audience here, Pawan?
Sir, yes. Just a minute, sir. Yes, sir. We do have some questions, isn't it?
In the meantime, when people are coming up, I would like to put some comments and as well as questions on the talks that we had. So Dr. Nipun very nicely mentioned that releasing the annular cleft is a very vital step for doing a transfemoral surgery. As many times beginners may think that, okay, I have docked the cannula perfectly and the disc is right in front of you. They can start
He will help us. I
grabbing the
don't know where
fragment.
the yes, right. In pilot, yeah. No, in this.
Can we request the people to
I
be on
already
mute?
discussed this one. Yeah.
Pawan, Pawan, there are some people who are not on mute. Can you mute all of them? Yeah, thank you. So releasing the annular cuff is vital so that you can easily remove the fragment as a whole. Otherwise, it may happen that the fragment tends to get broken and then you are at loss, because once the fragment gets broken, your tail, which is to guide you to the fragment, is lost, and then you will be struggling to explore the epidural space, which may lead to some bleeding. And the moment you have bleeding, then you can't visualize where it is coming from, and that can compromise the end result of your surgery. So it is important to release the annulus. Dr. Ankush mentioned about holding the scope. So it's a very important step for interlaminar, because many a times, me and Karunakaran, we have discussed that transforaminal surgery is difficult to conceptualize because people have not learned this approach from their earlier teaching, because that approach has hitherto been unknown. But most of the spine surgeons and orthopedic surgeons are familiar with the interlaminar approach. So it is very easy to learn that, okay, you dock that cannula onto the interlaminar window, you excise the flavum, and then you go to the neural elements, retract them. But the challenge is in different domains here. Transforaminal, once you understand, it is mathematical. 2 plus 2, 4. You put the needle in the correct space, your cannula is going there. The moment you introduce the scope, the next thing that you see is the herniated disc. And going by Nipun's description, you release the annular cuff and you remove the fragment, and that's it. But the concept is difficult to comprehend. The moment you understand, it is easy to execute. On the other hand, interlaminar is easy to understand because you are familiar with the approach, but the challenge is to hold the scope with your hand on the one side. There is no assistant. You are only holding the scope, you are only holding the cannula, and then you are using the long instruments with your other hand. So this is a surgical adaptation that a surgeon has to learn. So either you will have to keep the table position low, or you have to use high stools so that your shoulders do not get hurt and you do not develop rotator cuff issues and you do not develop fatigue after a long procedure. Dr. Sharma very nicely mentioned about bleeding control, and he showed some excellent tips. Almost everything that could be done to control bleeding, he mentioned very nicely. And these are all the 4 or 5 things that one can do if you come across bleeding, and that was really worth remembering. Visibility, as he also, Dr. Sharma clearly mentioned, is very important, and you should not grab anything that is not seen. I always say that if you are opening the instrument and your camera is getting blocked, so it is required that you rotate the hand of the left side to rotate the scope so that this can throw light at a different angle, and then you can see the instrument getting opened in front of you. So then you will be much more confident to grab any structure. Dr. Sharma talked about furcal nerves. I'm not sure whether many of the faculty or many of the audience here is aware about this entity, but a lot of work on this has been done by Dr. Anthony Young and his disciples. So the furcal nerves are the extracanalicular neural connections that sometimes join the two exiting nerve roots. And for transforaminal approach, they are important because even if you are doing it in local anesthesia, one case Dr. Nipun showed that the nerve root was lying low. We always teach that you should always see the parasagittal sections to check where the location of the nerve root is. And if the nerve root is in the lower half, then transforaminal is not indicated. But even when the nerve root is in the upper half, sometimes furcal nerves can cause significant amount of pain. And if the patient is having pain, then one can abandon the procedure and go interlaminar. So this is my own summary of all the important talks. One more thing, if your bleeding doesn't get controlled, one can always use a percutaneous drain at the end of the procedure through the same cannula that you have introduced. So you can introduce a small caliber drain and stitch it to the skin, leave it there for 1 day, and any bleeding that happens, the moment you turn the patient, a lot of bleeding tends to subside. But if there is to happen some bleeding, that will not cause a hematoma and a bed for infection. So, Pavan, can we have the questions from the audience now?
Can I also ask a
Sure,
question?
sure, sir. Most welcome. Please go ahead.
Okay, so Dr. Arun, we started doing it way back in 2001. You
Yeah.
know. Now, the question is that in which cases would you like to do it inside out or outside in? And what will be your end point? I mean, how do you, decide that you have done the job?
So, inside out and outside in, because this term was not talked about in the talks, I'll just explain. Inside out means that you keep the cannula inside the disc, and then you clear the base of the herniation first, and from there you grab the tail of the fragment, deliver it from the epidural space into the disc space, and then you take it out. So that is why we call inside out. But the outside in is that you dock the cannula in the epidural space only. So by these two terms, one can differentiate where to deploy. When the herniation is migrated, sequestered, there is no need to go into the disc. You can always go outside in or into the epidural space and simply remove the sequestered herniation. If there is a contained herniation connected to the parent disc, then it is safe to dock it within the disc space, and then you remove that as an inside out. Dr. Karnakaran, you have any difference here? You are mute. Can you unmute yourself?
Yeah.
Okay.
Yeah, I definitely agree. Like uh, what I personally experienced was whenever we go into the disc, the earlier days, we are comfortable. We see it's a bloodless feel, and then slowly coming out, and they can control the epidural field very effectively with the RF, and then we can get the collar off the fragment and come out. That is what I used to do earlier. But now, as we got familiar with the use of the RF, we can go step by step, control the bleeding, and then go behind the fragment. That's for all extruded or predominantly fragments outside the canal. I agree with you, Dr. Arun.
Nipun, anything you would like to put in from your side? You're mute. Can you unmute yourself?
Sir, I fully endorse that all cases where there is no significant fragment inside the disk, we need to go from outside, grab the disk and come out. There are instances when we find that there is a large fragment which is lying inside the disk and it has a tail, we can pull it in. But even if we do that inside out technique, I still would go out, check all the nerves, put my probe twice, and then come out because a lot of times you get a fragment, but later on you realize that there is a fragment still lying inside the canal. Some part has broken off or, just pressing onto the nerve root.
So you mean to say that after doing the inside out, you then rotate the cannula, take it at the edge of the foramen, and
Yes.
then look under the epidural space. Sir,
Yes.
answer second part of your question, you said, how do you make sure that the end point is achieved? So I personally use this logic that the transforaminal surgery is a reverse sequence surgery. In interlaminar, you cut the ligamentum flavum, you visualize the nerve root, you retract it, then you see the disc herniation, then you remove, then you feel with the hook or the probe under the nerve root to see are there any remaining fragments. But in the transforaminal, you'd see the disc material first, which is pushing the neural elements dorsally. You decompress it, and when you remove the fragment, you start seeing the neural element, the traversing nerve root. So one should see the traversing nerve root. Let's say if it is a L4-5 transforaminal surgery, we should see it from the lower end plate of the L4 to the upper end plate of the L5. And if you can just withdraw the cannula a little beyond that, if that area length of the nerve root can be visualized with the endoscope, this will happen only once you have removed the herniation. So that becomes the end point. The second endpoint I use is to ask the patient, if the patient is awake, we tell them to cough and we see the free pulsations of the dural sac. The third is, if your patient is under general anesthesia, you can ask the anesthetist to do a Valsalva maneuver, and that can also create the same kind of pressure to see whether the dura is pulsatile or not. So these are the three endpoints that we deploy. If you do something different, please guide us.
Dr. Nipun, I just heard you. Can you hear me?
Yes, sir, of course.
So you just said that in the inside out, once you have done it, you would like to go outside in. So inside out means you have entered the disc a little further away on the lateral side and you have gone up to the rent and then you have taken the pieces out, right? Now, would you like from this point to that rent from where the disc has extruded, would you like to cut the collar of the annulus? The annulus which is between your entry point and the rent from where the disc, which is at the lateral recess, which may be say about a inch or so, or maybe less, about half inch. So would you like to cut the annulus to just spread it open to see the disc herniation, or you just said that you would like to see it from outside? So how would you see that? I mean, just for my...
Sir, usually I just widen the annular towards the midline a little bit. It would be around 5 millimeter or so. Then when you retract the working cannula, you can simply reposition it a little into the epidural space, feel around with the hook. If nothing is coming out, then probably that is the end point.
Okay.
One more small thing that Dr. Banot also used to do earlier. He's probably not mentioned it. So we will look at the MRI and we will just judge the size of the disc fragment. Now, if we have taken out the fragment and we are satisfied that it roughly matches what we have taken out, we'll be satisfied. If there is a huge discrepancy, like the size of the fragment we measured on the pre-op MRI is quite more than what we have taken out, then of course we have to extend the annulus. We keep on searching and looking more and more.
Yeah.
More like a clinical radiological correlation of the size of the fragment you take out.
So this question was actually
Yes,
for you,
yes.
Dr. Banot. If I will just extend it a little more, Suppose the disc extrusion was, it was a central disc. So how are you going to do it, Dr. Bernard?
Most of the
What will
central
be your
discs,
steps?
yeah, most of the central discs I recommend treating transforaminally. And there is a slight change in approach. Normally, for a paracentral herniation, we tend to dock the needle tip at the medial pedicular line, once in the lateral view, it is at the posterior vertebral line. For these herniations, I would take my entry point 1 or 2 centimeter further laterally, so that the cannula can be coming at a rather flat trajectory. Again, using the facet first to touch the facet so that there is no visceral violation. From there, we get inside. The tip of the needle can be 1 millimeter medial to the medial pedicular line in this case, because the large herniation, the central herniation, has already displaced the dura and the traversing
Yeah,
nerve
so
root
it's safe.
further dorsally. So there is enough space. There is no need to worry the dural violation. Then you can position the cannula a little more medially. So if I can describe this, the tip of the beveled cannula will be across the midline in the AP view when it is showing half and half in the lateral view. So if I can achieve that, there is a good chance that a central disc can be fully removed by this position of the cannula.
Great. One more question. I'm sorry if anybody else is not asking, that I'll ask.
No, we are waiting for Pawan to tell us the audience questions
All right,
also.
all right. I think audience should
Pawan, do
ask.
we have some?
Yes, sir. We have some questions, sir. Can I read out it, sir?
Yes, please read out. First, we will answer their question, then we can discuss.
Yes, sir. Like the first question is from Dr. Ganeshwar, sir, Visakhapatnam.
Okay.
That is full endoscopy versus UV. Can you please explain, sir?
So, Dr. Dr. Ankush very nicely explained why full endoscopy and UB are different. So, in UB, the surgical steps, if anybody is doing UB, you will realize that in microsurgery, you are, Ankush, would you like to take this question actually? Because you talked about it.
See, for UV, we do it by making two ports, and we expose the lamina and we have to take out the whole of the ligamentum flavum. Then only, like it's like a micro discectomy, you do microscopic. Only then we can expose the nerve root, retract it, and go to the disc hump. And the retraction is going to be much more than the interlaminar approach in UBE. So that is the main difference between those two procedures, according to me.
So, see, in UB, as Dr. Ankush said, you have to excise the whole of the ligament. You have to do a little bit of laminotomy in most of the cases. Whereas in interlaminar and full endoscopy, uniportal, you create a slit in the ligamentum flavum, as Dr. Ankush showed very nicely in one of his videos, just 2 to 3 millimeter slit. Now, we have had a chance to treat a couple of our own patients who underwent interlaminar discectomy with the endoscope, and 3 4 years later, they came with a recurrence. So when we went in again, we found that the ligamentum flavum had regenerated and it was like a fresh case. You could do the similar type of a interlaminar approach in such cases because you didn't excise the ligamentum flavum. It repaired quickly and developed a full layer of the flavum on its own. So that is where the big difference is. Now, if you are treating stenosis, then probably UBE and full endoscopy are similar because we are also doing a laminotomy. We are also excising the whole of the ligamentum flavum. So in that case, UBE scores only on one point, that the instruments are cheaper. Otherwise, the cut is, again, you have to do two cuts. You have to do a joystick manipulation. You have to create a what we call as a Song's window, where the bony window just on the spinolaminar junction is to be cleaned of the soft tissues by a water pressure, and that lifts a lot of muscle from the posterior vertebra lamina. So in the full endoscopy, you do not have to do that. You have to only clear that muscle which is covering the lamina that is to be drilled. Beyond that, you don't have to do anything further.
Okay. Any other question?
Sir,
Yes,
sir, next question.
yes, please.
Yeah. Sir, Dr.
Pranab,
Sunil
there
Katwaji,
is
sir, the same question is sir asked. And next question is sir, Dr. Aditya Punia Jaipuri, sir. What are the risks and potential complications for ESS?
EFS?
What is EHS?
ESS.
Endoscopic spine surgery. I think Dr. Sharma took an extensive lecture mentioning everything what can go wrong. So I
So
think
we,
that question
we
has
require
been
15 minutes to answer this question.
But anyway,
Actually, Manoj, I think that question was typed before Dr. Manoj took the lecture.
Maybe, sir. Correct.
okay, okay.
So there is a question, Manoj, for the arthroscopic surgeon.
Your voice is
Endoscopic
cracking,
spine
Guru.
surgery
Your
is
voice
quite
is
serious.
cracking.
Can you type it on
Guru,
the
your
chat box?
voice is, wavering a little.
We can't hear.
Okay, Pawan, you can take it.
Sorry, sir. Which one, sir?
So they say the question is whether endoscopic spine surgery is easier for arthroscopic surgeon.
Oh,
Huh?
yes.
Of course, yes.
I would say
Anybody.
But I would say frame it in a different way. Endoscopic spine surgery is easier for practicing spine surgeons rather than only arthroscopic surgeons, because to do the endoscopic spine surgery, knowing regular spine surgery is much more important a skill than the skill of pure arthroscopic surgery.
Arthroscopic, UBE would be a better choice for them. Because triangulation is what you require there. Here, you don't need it. This is good for anybody.
If I
I'm
may
talking
come
about
in,
transference.
I'm hardly done any arthroscopy surgery, but
I could never triangulate in my life. So
Yes.
arthroscopy always scared me. When I was putting two things, they would never meet at the same point. So I never liked it. And so UBE is the similar kind of a thing, because
We are birds of the
arthroscope is
same
present
flock. Then.
everywhere. So people
I am
start doing it.
also in the similar category.
Actually, UBE is a different game, and most of us are not doing it. So asking this question that which is better, this should be done to those people who are doing both. So for us, this question would be difficult to answer.
No, UBE, we are in that process, but as I said, it has its own indication, but it is not.
You just told me.
For discectomy, I do not endorse it. For one level stenosis or two level stenosis, also not. But when you have to do multi-level, then probably the time taken for full endoscopy is a little higher.
Yeah.
There UBE might be scoring in that case.
I would just like to say one thing, that transforaminal is the least traumatizing procedure.
That goes without
where
saying.
we do not violate the posterior structures, and all other endoscopies are doing the microdiscectomy in a little different way. Now, transforaminal is we land up straight away into the disc, not touching touching but not damaging anything. So, it's not that since I do it, so I will prefer it. But that's how it is.
But that's principally, yes, that statement is correct. Yeah. Any more questions, Pawan?
Yes, sir. Last one is what is Dr. Akhil is from Jammu. Sir, what is like spine endoscopic future in rural India, sir?
Very good.
So naturally,
we do it in local anesthesia.
Yes. So Dr. Manoj already answered. When you can do it under local anesthesia, so your dependence on anesthetists, especially in rural areas or tier 3 towns, is restricted. So you do not have to depend much. Of course, we do require some kind of a anesthesia backup, but at least not all the time if you can do a transforaminal surgery under local anesthesia. Secondly, as it is a daycare procedure, it can deliver fast return to work where people may not have that kind of absence from work. They are running their own business by themselves. So such cases, such cities will definitely have a great potential for endoscopic surgeries. Karunakaran, would you want to add something?
Dr. Manoj, I've got one.
Please unmute yourself.
One last thing.
Dr. Karnakaran's
Dr.
comment and then yours.
Yes.
Yeah, it's a very important question. Like in rural India, it's a good point to focus, but I think the cost is maybe a little bit forbidding as far as the rural areas are concerned. But other than cost, I think if the technology, we wish that we could take technology to that level. That is I think should be our vision for the future.
Yes, sir. Dr. Sharma, please.
Dr. Bro, this question is for all of us.
Yeah.
Are you doing the lateral recess stenosis by the transforaminal approach?
I don't do that. I usually choose interlaminar approach.
Because there are lots of paper, many people have started doing it.
Yeah,
Foraminal stenosis they were doing before, but
foraminal
how about the
stenosis
lateral
we still
recess?
do, but lateral recess stenosis, personally, I'll tell you why. Because what is lateral recess stenosis? It is the overgrowth of the undersurface of the facet, which is pinching the traversing nerve root from the posterior side. Now, if we have to access that part of the facet, it means that we have to bear the whole lateral surface of the traversing nerve root first, so that we can visualize the part of the bone which is causing pressure from the posterior side onto the traversing nerve root, which is not very easy. It requires extensive bony drilling of the pedicle if
Yes.
you want to reach there. So I personally don't endorse that approach. If somebody else from here is doing, maybe we will get enlightened. Nipun, Karnakaran, you can share your experience. Unmute, please.
No, you can always drill the undersurface of the facet, and
Yeah, you
then
can
you can go
undersurface of the facet is okay. So, but lateral recess narrowing is actually causing pressure from the dorsal side of the traversing nerve root.
Yes, yes, yes.
So that is a challenge in my understanding.
So you will have to drill the pedicle as well, actually. So this is a technique which you have to do.
Are you doing
No, sir,
Karnakaran?
See,
No, we have started doing it now.
Yeah, only when we see that there is an exiting nerve root which is getting pinched, where there we would do a foraminoplasty to make the exiting nerve root free. Otherwise, the traversing nerve root portion, I think I would do an interlaminar.
Nipun.
Same here, sir. Even in most of the cases where I find there's significant stenosis, I would definitely not going for transforaminal, and in a lot of cases, I would rather going for microscopy, to be honest.
Okay, fine. Ankush.
Yeah.
Your take, Ankush.
See, as Dr. Karnakaran also mentioned, we have used it to drill just to release the pinching of nerve, not the whole lateral recess stenosis. Because to enter lot of bone, like Dr. Manoj Sharma mentioned, we might create an instability if we drill too much.
Let me tell you that most of the stenosis are at the level of the disc, and transforaminally you can see the disc. Now, lateral recess and if it's a unilateral, and if it is not much, just by drilling, because disc up and down, you can see both end plates of the disc. You can see the whole thing. So if you can drill the facet, if you can drill the undersurface of the facet, the superior SAP as well as the inferior on the medial side, you can take care of it. And the patient, I'm not talking about the severe one where you have to go down, but essentially you have seen that all the stenosis are at the disc level. That is why they have the spinous process spares and all those things. So, those parts. So, you can start with a minor stenosis. Maybe it might. And then Arun will tell us after about a month or two, I'm sure he's going to do it.
No, sir, I principally do not align with this thought, because I told you, in my understanding, lateral recess narrowing is below the disc level, because that is the area which is just at the end plate of the caudal vertebra and the pedicle. So that is the region where the narrowing happens. So we have to drill a lot of bone to open this up, and that is because endoscopic surgery is we have to do the least invasive treatment. So if by just pursuing a transforaminal, I have to drill a lot of bone, then I am not keen. Rather, I would rather do a interlaminar, because again,
look, instead of removing a lot of bone, if you just do the undercut and then you remove the flavum, So because phlegm is attached with this. So if you remove that additionally, I think the job is done. Otherwise, you have to go down and you have to burr the base of the SAP. And then along with the base, you have to come down and maybe a little bit of the pedicle. So that's what they do. I mean, with passage of time, we'll learn it.
Few cases from someone, and then we can get to know.
Yeah.
As I said, I would rather choose a easier and a reliable approach, which in my hands is interlaminar approach for a lateral recess stenosis.
That's nice. That's nice.
So, if there are no more questions, can we wind up now? We have had an interesting and a very engaging session. Pavan?
Yeah, we are already half an hour late, so we can wind up.
Thank you everyone for sparing your time, and special thanks to Karnakaran to join us. We are all members of Delhi Spine Society, and we welcome and thank you for your time.
Thank you, everybody.
Thank you very much, Arun and the entire faculty.
Thank you,
It was a
sir.
wonderful opportunity.
Guru,
So, and thanks,
everybody.
Arun, for your slide as well. Thanks for that.
Okay, bye-bye.
Thank you, sir. Thank you so much.
Thank you. Bye-bye.
Bye.
Thanks. Very good job done, Arun.
Thank you, sir.
Great job. Thank you.
Thank you, sir.
Thank you, sir.